Welcome to the research training course. We are coming to the end of our training course during month of Ramadan. Our last module is the research methodology, and our last presentation in this module is with Dr. Al-Anoud. We thank her for her time, for being here with us. Without further ado, I will pass it on to her to introduce herself and take over her presentation. Dr. Anoud, welcome.
طيب السلام عليكم. يعطيك العافية سالم. Thank you very much. مساء الخير جميعا. I appreciate being with you again tonight. بس بتأكد is the slide shared صح? You can see it?
Yes.
Okay, بس يمكن أنا I'll just go with the start. طيب. بسم الله الرحمن الرحيم. So today inshallah, or tonight, I'll be talking about utility of screening and diagnostic tests. So screening is a presumptive identification of unrecognized disease in an apparently healthy asymptomatic population by means of tests, examinations, or other procedures that can be applied rapidly and easily to the targeted population. So why do we do screening tests? We do screen in order to uncover the covered portion of the disease, to uncover the submerged portion, which usually indicates the hidden burden of the disease before the symptoms appear and before the symptoms appear to the surface and before we see the top of the iceberg, where a lot of time it's too late to intervene when symptoms appear. So in order to know when to screen exactly or when to diagnose, of course, we need to know the natural history of disease. And I'm sure all of you are familiar with this graph. So we have maybe 3 or 4 phases of disease. We will start with the first phase where still it's before the biological onset of the disease, meaning that the individuals or subjects are still healthy and they did not contract the disease. And here where primary prevention plays a big role. And in my presentation today, I'll just try to give some examples of COVID-19 testings as we are talking about diagnostic and screening tests. So in the context of COVID-19, prevention here would be what all governments are telling their population, including our government, is stay home, social distancing, and keep hand washing. And by doing this, studies have shown that this is one of the most effective measures of disease prevention, COVID-19 prevention. While in the preclinical phase, where the biological onset of disease started, by definition, the patient has the disease, but the patient still is asymptomatic, which is the preclinical disease. And this is the most part or stage of disease where it's amenable for screening and where secondary prevention works perfectly here. And the outcome is very important and perfect. And alhamdulillah, now with the vision of 2030, we have shifted and moved from tertiary prevention to secondary, and we're trying our best to do primary prevention, also though it's going to take a longer time than secondary prevention. And in context of COVID-19, secondary prevention will be early testing before the symptoms develop and isolation. And this fits well with COVID-19 because majority of cases of COVID-19 patients or proportion are asymptomatic. And we have recently published a paper regarding our experience here in the Eastern Province in one of the quarantine, and we found around 64% of our patients are asymptomatic. So, and this is a big challenge for control of disease. And if you just base our diagnosis based on symptoms, I think we won't be able to contain the disease. The third is when symptoms develop. And it's still amenable for secondary prevention, especially if we catch the disease early after the symptoms in order to prevent further complications. A good example is diabetes. Sometimes you can diagnose this when the patient will present for the first time with DKA. However, we still can follow this patient and control his blood sugar strictly to prevent like nephropathy and retinopathy. And the third is when we treat the tertiary complications, like when we need dialysis, and this is too late in the game. So what are the criteria that makes screening tests effective? Or what are the criteria that we should, based on choosing which disease to screen? So there are certain criteria related to the disease itself, and another criteria related to the test, and third criteria related to the country infrastructure, policies, and economy. So the first criteria related to disease is the disease should be a health problem, should have a burden, should be a public health concern, like tumor, cancer. And since in our country, maybe non-communicable diseases is leading the causes of mortality, like cancer. So cancer is a good diseases that should be screened, like colon cancer, breast cancer, and also epidemics and infectious diseases that can lead to high mortality and morbidity, maybe like COVID-19 right now. And the other thing is the disease should have a detectable preclinical phase, as I showed you in the previous slide. Not only we can detect it early, but also after detection, this disease should be amenable to intervention, and the intervention should be beneficial. So we can change the natural history of disease, and we can change the outcome. Otherwise, the testing won't be cost effective. The disease must be prevalent, and this is a very important criteria for screening. If your disease is not prevalent, screening won't be cost effective. And if you are not screening that at high risk group, and you're just going blindly and screening everybody, your screening won't be effective. And an example is for COVID-19, if we just go ahead and screen every single patient without categorizing the patient based on their risk, based on the exposure, I think we will waste resources. And instead, the best thing is to allocate our resources in screening to those high-risk groups. For example, and like what the country is doing currently, certain socioeconomic status, like screening, laborers screening. And from my perspective as a nephrologist, I think screening dialysis patients periodically, I believe it's cost-effective because they are at risk of getting COVID, they're at risk because they're multiple exposure, they have to come to the hospital 3 times, 4 times. So they are a risk group. Instead of screening everybody, let's allocate our resources and focus on high risk group to get the best of this screening test. So now we'll talk about criteria related to the test itself. So the test should meet acceptable level of accuracy and cost, and I'll talk in details about this. And then the test should be feasible, practical, and not invasive, because it's difficult to convince people to go for invasive testing when they feel fine, because we screen asymptomatic. So it should not be invasive, and it should be cost effective for sure. And the most important part, the test should be sensitive, because screening test, you need to rule out false negative. And when you do screening, you are trying to rule out the disease. So you need to have a sensitive test. And then, as I mentioned, criteria related to the pre-readiness, the government infrastructure, ability to carry out these screening, and ability to manage the result of the screening test. So again, effective programs, you need to have what we call the call and recall. So you need to have an effective systematic mechanism to invite people to be enrolled in your screening program. And after their enrollment, you need to also recall mechanism, which is calling them in a systematic way and telling them, okay, you tested positive, you have to have a clear plan what you're going to do. And then another important point, you need to screen a good amount, a good percentage of your population, at least 70% to have an effective screening program. And here is an example of breast cancer screening. This study was published in 2015. I'm sure that we're doing much better than 2015. We're at 2020, and I know that the model of care is working hard on the mammogram and screening for breast cancer. However, in this study, 2015, the mammogram was free, but almost no takers. But this is a problem. So we always need to be sure that we are calling and recalling in order to get an effective test. Sometimes screening is not that beneficial when it's late in the disease course, or when certain diseases, maybe like lung cancer, screening them early will not change much because the outcome is not going to change by early screening and intervention, and when the prevalence is very low. We have some pitfalls of screening tests, as any test, and one of the pitfalls for screening is lead time bias. And lead time bias happens actually when the disease we are screening screening in these diseases are not effective because early intervention will not change the course of the disease. And lead time bias, basically, if you can see, is when we screen patients on the detectable preclinical phase, as here we can see that we are detecting the disease earlier than with diagnosis. With diagnosis, we are detecting disease based on symptoms appearance. And if you can see here in both examples, the outcome, which is death, hasn't changed. It's the same. Screening is the same. However, it appears a benefit, and in reality, this is not survival benefit. The only reason that the survival seems to be prolonged, that we detected the disease early and we classified this patient as diseased early. So this patient is living with disease longer duration because we know that he has the disease, not because the screening is effective. And the way to overcome this type of bias is not to look at survival when you compare in studies, is to look at age-specific mortality. A second important type of bias is the length time bias. And this has to do with the, again, natural history of disease. So some diseases are progressive and some diseases are more indolent. And a good example is prostate cancer. So prostate cancer sometimes, or some types of prostate cancer is really slowly growing. And like this is the long rectangle here is slow growing prostate cancer tumor, where in other cancers where it's fatal and rapidly progressive, you can't catch them with screening, because we said that in order to have a good screening, we need to have a high prevalence, or at least reasonable prevalence. And as you know, prevalence is a function of incidence and duration. So the more the duration with disease, like a slow growing tumor, the more the prevalence would increase. So we will be able to detect them. And let me draw an imaginary line here. And you can see, I won't be able with screen to detect all these small boxes if I put my line here. How to detect the diseases with slow growing. So slow growing disease to bias, again, similar to the bias of lead time bias, because they exist for a longer period of time. Not like fatal disease or fatal epidemics that would survive. Lastly, if you are more well educated, or you are worried about your status because you have a strong family history, let's say of breast cancer, you would step forward for screening and testing. So this is what we call, this is a selection bias or volunteer bias. Let's move to diagnostic tests. So we do diagnostic tests to establish diagnosis in a patient with signs and symptoms. And again, this applies for both. In order to have a good test, we need to have reliable and precise, and we'll talk about it in details. We need to have an accurate test, and then we need to adjust, and for other dependent, your test should be feasible and acceptable, and interference and cross-reactivities should not happen, should be limited, and we should also avoid inter and intra-observer reliability. So in accuracy, we'll talk about validity. Always to calculate sensitivity and specificity, for sure, we need to have a gold standard. And then we need to use our diagnostic thinking, therapeutic effectiveness, and patient outcome. This is a good picture that can simply explain what is the difference between validity and reliability. We always hear these two terminology in diagnostic and screening testing. If you look at the first circle, target A, you can see the small black circles are representing reliability. And reliability means if we are to repeat this test multiple times, this test should give us almost same result. And if you can see here, all the dots are close to each other. So that means this test has a good reliability, however, poor validity. And validity means the test should be here. A valid test is a test that is measuring what this test meant to measure. And in this picture, target is here. So every time I do the test should measure exactly what I want, which is the target. On the other hand, you can see target C. This is the best test where you can see it's reliable, and at the same time, it's valid because it's measuring the center, which is what I want from this test to measure. And a good example of tests that might cause a lot of inconsistency and unreliability that we should be aware of, especially as a nephrologist, is the blood pressure measurement. And blood pressure measurements can vary related to, because of biological variabilities related to the different time of measurements. That's why we always stress as a nephrologist that we never rely on one reading, because your sleeping blood pressure is different than when you're awake, when you are after exercise is different than when you are at rest. When you are upset or nervous, your blood pressure readings might be high. So there are certain biological variability related to the instrument itself, and variability related to the observer who is doing the test, and in between patients. Okay, test validity, which is now we'll go to the most important part of our presentation. Test validity can be measured by certain tests. First of all, sensitivity. So sensitivity means how accurate the screening test or even diagnostic test in identifying disease in people who truly have the disease. In other words, is the probability of testing positive giving you have the disease. The probability or how accurately you are identifying true positive patients. All these definitions are sensitivity. And I'll give you here an example. If you see a trick, I know that sensitivity and specificity is a bit challenging, you know, or a hard topic to digest, but it's a really very important. So a trick always in sensitivity and specificity, the denominator is the disease status. So in sensitivity, as we said, is the probability of testing positive, giving you have the disease. So giving you have the disease, that means the denominator will be the disease. So in this table or scenario, the sensitivity will be 132 over the all total diseased patients. So the sensitivity is detecting the true positive, while specificity will detect the true negative. So to calculate sensitivity in this scenario, so it's 132 divided by the total diseased population, and it will be 74.6%, which is not bad. However, specificity focuses on the accuracy of screening tests in correctly classifying truly non-disease. So a disease that can, a test that can detect the true negative people who will not have the disease, or the probability of testing negative, giving you don't have the disease. So again, the denominator will be not having the disease, and it's testing the true negative. So you will have the specificity here is 63,650 divided by the total non-disease 64,633. Specificity is a pretty good 98.5, excellent specificity. So quickly, sensitivity, true positive fraction divided by the diseased population. Specificity, true negative fraction divided by the disease-free or those who don't have the disease. And this is very nice mnemonics to memorize sensitivity and specificity and not to forget it. And personally, I memorize sensitivity and specificity by snout and spin. So snout is sensitive test, rule out the disease. So when you want to rule out the disease, you need to have a highly sensitive test. SPIN, on the other hand, is specificity. So when you want to rule in the disease, you will use a specific. Another good example to memorize sensitivity and specificity, sensitivity includes a false negative test, negatives. So sensitive test is a test that rules out false negative disease, while specific test is a test that rules out false positive disease. And lastly, sensitive tests are negative in health population, and specific tests are positive. Another way of memorizing this, when we do screening, let's say mammogram, our mindset is to rule out the disease. I'm not doing it to rule in. And actually, when I do mammogram and it tests positive, it would be like shocking, although because the purpose is rule out the disease. So getting a positive test in a screening is not that common. While in a specific test, the pre-test probability is high. So when I do the test, I'm doing it because I want to rule in the disease, because I'm expecting the patient is having the diagnosis that I'm trying to rule in. Okay? The problem, I wish that sensitivity and specificity is that easy. Unfortunately, it's very difficult to find a disease, a test that is 100% sensitive and 100% specific, or at least 90% sensitive and 90% specific. And the reason is there's always a trade-off between sensitivity and specificity. The more you go up with your sensitivity, you will reduce your specificity around. When you increase your specificity, your sensitivity also will go down. All right? So how can we decide about which test do I want? Do I want sensitive test or I want a specific test? And here is a hypothetical example. Let's imagine we have a 20 diabetic patient and a 20 non-diabetic patient, and I want to diagnose them based on a blood sugar test. Here is a high and here is a low. Let's start. So if I set my screening test, which is the fasting plasma glucose, low or too low, I will be able to accurately and correctly identify 17 patients who actually have the disease. All right? On the other hand, I will miss 3 patients who actually have the disease, but my test did not detect them. And this is the false negative result. So according to what I said, 17 positive, 3 negative, if I calculate sensitivity, as I taught you before, 85%, this test is 85% sensitive, which is pretty good. However, by setting the bar or the cut point for blood glucose low, I mistakenly positively, falsely labeled around 14 patients as positive, and in reality they're not. So my specificity is 30%, and you can see clearly this trade-off. Sensitivity is great, specificity is terrible. What would happen if I set this cut point higher? So by doing this, I will be able to correctly identify 5 patients with diabetes, and they have diabetes. Here, they are true positive. However, I'll miss 15 patients, right? So the false negative rate is high, and so meaning my sensitivity will be only 25%. On the other hand, I'll be able to accurately identify those who don't have the disease. So the true negatives, 18, and my specificity is perfect. Let's make this example more difficult. In reality, in a typical situation, there's no separation between these two. There's no separation between non-diabetic and diabetic. And in fact, to make it more difficult, in reality, there is no color label at all. And we don't know who has diabetes and who does not have diabetes. So this makes our job is more difficult to decide about which cut point should I use. So a screening test using a high cut point will treat the button box as normal and will identify, as I mentioned, above line as having diabetes, and exactly apply to when the opposite. So the question here are different cut points yields different sensitivity and specificity, and I clearly showed you that. And the other thing is the cut point. So the cut point determines how many subjects will be considered as having the disease, and the cut points that identify more true negative will identify more false negative, and the cut point that identify true positive will also identify more false positive. Okay, it's still it's not easy. So where to draw the cut point? And here are some practical steps to go through. Ask yourself if the diagnostic test is expensive or invasive. If it's expensive or invasive, and I want a test that minimize false positivity, right? Meaning, I want the cut point to be high and I want my test to be specific. Sorry, I want my test to be highly specific. On the other hand, if the penalty, and these are very important questions you ask yourself, because the performance of diagnostic test depends on what you want from the test. It's not depends on, I'm gonna run this test. No, what do you want to answer from and what do you want to get from this test? This is a very important concept. So if the penalty of missing a case is high, because the case might be fatal, communicable disease, like currently COVID-19, the penalty of missing a patient who has a COVID-19 by testing negative falsely is very high. Maybe not only on the penalty is high on the patient himself, but on the public health system also, because you will falsely allow and release this patient to the community. And we know that this COVID-19 is a very, very contagious disease. And this one person who you released by not choosing the proper test for screening will lead to thousands of infected population, will increase the case fatality rate or the people who will die because of this infection. So if the penalty of missing the disease is high, I want a very sensitive test that can minimize false negative. False negative here accounts more than false positive, okay? When the disease is fatal, it's exactly the same thing applies with cancer. When I test for a cancer, when I screen, the penalty of missing patient with cancer is way higher than the penalty of mistakenly labeling this patient of having cancer and he doesn't have cancer, okay? So we need high sensitivity. And here are simple examples. I just want to show you that it's difficult. It's not impossible to have a screening and test with good sensitivity and specificity, but always there is a trade-off. You can see here for PSA 3297. Here, ELISA test is very sensitive and very specific. And I think also in the context of COVID-19, doing ELISA test and assessing the prevalence of seroconversion by ELISA test is the best way to accurately detect the prevalence of seroconversion, better than qualitative antibodies assays. So here's a quick only how to differentiate between screening and diagnostic testing. I already mentioned all these differences. Okay, so choosing diagnostic test. How can we use the best and the most appropriate, accurate diagnostic test? First of all, and this is a very important concept, think about the pretest probability before ordering any test. And we'll go in details in a few minutes. The second thing, ask yourself, what do I want from this disease? Do I want to rule in the disease, or I want to rule out the disease. All right. So how can I come up with a pretest probability? Meaning, okay, I have a patient who came to the emergency room with certain symptoms and signs. What is the pretest probability? And it simply means, what is your differential diagnosis? Or more accurately, what is your top differential diagnosis? So this is the pretest probability. This depends on previous study disease probability. Some certain diseases, like maybe I believe like PE has a certain criteria for diagnosis. You can base on these predictions. If my patient come with this symptoms plus this symptoms plus this sign, most likely the pretest probability is blah, blah, blah. And again, on your clinical expertise and judgment, based on your knowledge, you can decide based on the constellation of findings and symptoms and physical exam, what is the pretest probability. Very important concept in choosing the proper diagnostic test. And again, the concept of ruling in the disease, if you want to rule in the disease, then you need to have a high pretest probability. And I'll give you an example of COVID disease or COVID. If you think that your pretest probability is high, and in the context of COVID, if you had a direct unprotected exposure to patient with COVID-19, unprotected, you're not wearing face mask, you don't have any PPE, and you stayed with this person like 30 minutes or less than 2 meters, like the definition of direct exposure by WHO and CDC, your pretest probability is high. Since the disease is very contagious, your probability of test is to have COVID-19 is very high. So, meaning that you need to rule in the disease. And in order to rule in the disease, you need to choose a very specific test. On the other hand, if your pretest probability, if you want to rule out the disease, that means your pretest probability should be low. عادة, when you rule out the disease, your pretest, it's the same concept of a screening for malignancies, right? So when you screen, because the pretest probability is low, but I want to rule out the disease, so you need to choose a sensitive test. Rule in, you will use SPIN, which is specific. Rule out, SNOUT, sensitive test. And this is, I believe, this is one of the most important slides, if not the most important one in my presentation. The disease probability is continuum, and you can have from 0 probability to 100% probability. So the test threshold occurs somewhere here. So when the test threshold is below 20%, that means you are below the testing threshold. So you don't need to go for test. Leave your patient alone. And I'll give you an example for this. You have a 9-year-old presented to the emergency room with a chest pain. And when you examine the patient, while examining him, you realize that the pain mainly is with movement, meaning is more towards a muscular pain. Otherwise, patient is vitally stable, saturation well, heart rate is perfect. So what I would do, I will send this patient with a painkiller, maybe gel, marham, and I'll send him home because I'll reassure him. So based on my pretest probability, it's less than 20%. So it's less than the threshold of testing, so you can go home. On the contrary, on the other extreme, when your pretest probability beyond the treatment threshold, meaning that your pretest probability is very high, 80% and above. Do we need to do testing? I'm not sure if I have a good example, but I'll give you a different example, an extreme of the one I gave. You have 70-year-old guy with a lot of comorbidities, hypertension, diabetes, ischemic heart disease, coming with typical chest pain, describing it as pressure on his chest, radiating to the jaw, he's numb, and saturation is dropping, he is sweating. So all these goes with acute coronary syndrome, and he had all the comorbidities, high cholesterol. This is beyond, and sometimes interfering should be very quick. So instead of wasting your time and doing further testing, go ahead and treat. Maybe the treatment is diagnostic and therapeutic, go take him to cath lab. So these are the two extremes. When the test is below the threshold, of testing, don't do anything. And when the threshold is within beyond the treatment threshold, don't do anything. Go ahead and treat, okay? When to diagnose? When you are here in between 20 to 80, I'm not quite sure what I'm dealing with. I have 5 differential diagnoses, and in order to refine them and reorder them, I need to test. Okay, I test chest X-ray, let's say, or ECG. This is not ischemia, and so on. It's not clear to me. Okay, so we need further diagnostic testing. Okay, in the context of COVID-19, this is a very important slide, and I believe this is the only study that have interpret correctly and nicely, or the only study that highlights or shed light on the interpretation of COVID, and it was published in JAMA, I believe, on May 6th. So here they looked at the different tests used in diagnosis of COVID-19. And back to what I was describing, we need to ask ourselves, what do we want from the test? We all know that the gold standard, or although I'm not quite happy with this, but at least this is the only available test, is the PCR, the reverse transcriptase PCR, is currently the gold standard test. So the gold standard test, let's start with the blue curve, which is the PCR. If you look, the PCR can be positive at least 1 week and around the time, as early as the exposure, maybe 2 to 3 days after exposure, and it peaks here, maybe like 5 days or a couple of days before symptoms, and it plateaus for a while, and it can persist up. Red one is the virus culture, where also it can appear early, you can detect the disease early. However, it disappears and turns negative at almost day 8. Meaning that PCR and viral culture are a very good test to detect the disease in the acute phase. So knowing the timeline and what your test is detecting is very important to tell you how appropriate or in what the test is doing. However, everybody, and I think in the media, are talking about antibody testing, and I feel they are over-exaggerated and they're very optimistic, 100% sensitivity, 100% specificity. It can accurately diagnose the infection. You can see that they appear at least a week, and week 2. So week 2, we are too late. If I want to early detect and isolate and apply a proper containment measure, I don't want to miss this patient for like 2 weeks, roaming around and spreading the infection. So what this test, antibody testing, using the qualitative assays, will only tell me whether my patient is positive or negative, meaning it will only tell me about the prevalence of seroconversion. Did the patient have the disease? It won't tell me anything about whether the patient has acute infection right now, okay? Except when we use ELISA testing, and as I mentioned, the ELISA testing and is a really sensitive and specific test, and it can appear as early as 5 days. So if you have antibody detection using ELISA test, you can use it for acute detection. However, still, ELISA test will appear 5 days post the symptoms, and we won't be able to detect it early. However, the problem, that's why I said it's difficult to say it's a gold standard, because the gold standard screening test should have a high sensitivity, at least 95% and above. And this is a study done by the Chinese group in Wuhan City, where they studied 205 COVID-19 based on PCR. And here is a big, I think, little limitation of this study, because the gold standard is the same test that they are using. And as I showed you in the 2x2 test to calculate sensitivity and specificity, the gold standard always need to be a test that can really 100% or 95% tell you that the patient has the disease. So they tested 1,070 samples. 15 were from bronchoalveolar lavage, and out of the 15, 14 were positive, with positivity of 93%. While fibrobronchoscope brush biopsy, 13 sample, 6, almost 50% were positive. Sputum, 104, 75 were positive, so 72% positivity rate. Nasal swab, 8, 5 positive, 63% positivity rate. Pharyngeal swabs, 398 pharyngeal swab. And this is the most common, nasopharyngeal swabs are the most common, with pharyngeal swabs are the swabs we're doing. And you can look at the pharyngeal swab, only 32. Even nasopharyngeal swab, 63%. So 60%, this is not, although as I said, I can't calculate sensitivity here because I don't have a gold standard, but I can imply sensitivity. 63% sensitivity is not great at all for screening test for infectious disease. Feces, here it can last for a while. So we have a huge problem with PCR, because that means we learned from this study the PCR depends on the source of the specimen. And apparently, the deeper you get your sample, the higher the yield. Meaning, if your pre-test probability, and this is a very important lesson, if your pre-test probability for COVID-19 is high, based on the direct exposure, unprotected, even if you get negative test, you should continue to treat yourself as positive, isolate yourself as positive. And there are certain reasons, couple of reasons for false negativity in COVID-19. One, as I mentioned, is the source of the sample. The second thing is the time where you tested your patients. If you test them very early in the disease, immediately after exposure, you might fail to detect the viral load, or the virus shedding is not that much. And the third thing is the process. Of course, the samples needs to be processed in a certain technique under certain temperature. So there are a lot of factors that can contribute to high false negativity rate in PCR. So until we make sure 100% that we are adjusting all these factors, I think we can't 100% rely on it. It gives false negative test, in my opinion, in COVID, gives you false security or false sense of security, and PCR tests are more beneficial when they are positive. So consequences, I mentioned it, of low sensitivity test in COVID, high false negative rate, false reassurance, inappropriate release of mitigation measures, and further disease spread. Positive predictive values. It's a very important also concept. Positive predictive values are the more intuitive interpretation actually of diagnostic testing. And it simply is exactly what your patient is asking you in your office. So, okay, I tested positive in my mammogram for breast cancer. So the question your patient will ask you, doctor, what is the probability of me having breast cancer given I tested positive? And you can see the denominator here is different than the denominator of sensitivity and specificity. Denominator and the condition is test. And negative predictive value, what is the probability of me not having breast cancer given I test negative? Okay, and this is very intuitive, more practical implication. However, it has a major problem that, and here is a quick example for the sake of time. I told you in perpendicular, you should check because the denominator is disease, and predictive value go horizontal because the denominator is either test positive or test negative. The problem with the predictive values is it's affected by prevalence. And this is really important to consider when you interpret predictive values. So low predictive values will give you low prevalence will give you low predictive value. And I'll give you a good example. This hypothetical example, you are testing a group of female, they are blood donor, and you are testing HIV. HIV is screening test is a very sensitive test. However, because the prevalence of HIV in female donor, of course, is very low, when you calculate your positive predictive value, it's only 1.9%, though the sensitivity of the test is 100% and specificity 95%. Can you see? This is a very important point. If you increase your prevalence and you make your group a more higher risk of developing HIV, which testing sexually, male coming to clinic for sexual transmitting disease, the prevalence calculated is 4%, and you can see the predictive values at 83%. It's much better. Let's make it more and more beneficial when you screen IV drugs users, intravenous drug users, where the prevalence of HIV among those are 20%, you can see how your positive predictive value went up to 98%. Last thing to discuss is likelihood ratios. So as I told you, sensitivity and specificity are not towards the clinical practice and interpretation. That's why we use predictive values. However, predictive values are affected by prevalence. So let's go for something else that is practical in interpretation and is not affected by prevalence, which is the likelihood ratios. So likelihood ratios simply is the probability of individuals with the condition to test positive and the probability of individuals without the condition to test positive. So positive likelihood ratio is used when the test is positive. Positive, positive. The test should be positive. So the probability of testing positive, giving you have the condition divided by the probability. And I think this numerator is familiar to us. The probability of testing positive, giving you have the condition. This is sensitivity. While over the probability of testing positive, giving you don't have the condition, this is the 1 minus specificity. So likelihood ratios are, positive likelihood ratios are best used when you want to rule in the disease. It's exactly like the sensitivity. It's best when you want to rule in the disease, while the negative likelihood ratio is the opposite, probability of testing negative when the individual has the disease over the probability of testing negative when the individual does not have the disease. And it's 1 minus sensitivity divided by specificity. It's best used when you want to rule out the disease. And here is what they call it, normogram for the likelihood ratios levels. Any likelihood ratio of 1 is useless. That means it's not gonna change in your test probability. And likelihood ratios are very important to detect your post-test probability. And let's say here, 2, whenever your pre-test probability is positive and it's above 1, it will change in the post-test probability. So if you have 2, this will increase your baseline test probability by 15%. And if it's 10, 45%. Let's say the baseline pre-test probability is 20. If you choose a test with a likelihood ratio of 10, you will have a post-test probability of 75%, and negative is less than 1 is the opposite. It will decrease the pre-test probability. And here's the nanogram. You can find it in textbook, in articles. So we start with pre-test probability of 35%. If you have a positive likelihood ratio of 10 plus 45, you can go up to 80%. So it can calculate your post-test probability. And on the other hand, if you use negative test and you start with a pre-test probability of 20 and your likelihood ratio is less than 0.5, you will drop your pre-test probability by 20%. Okay. Here is a quick test, an example. If you were to choose a test that can tell you who has the probability of getting high probability of having infection, you have stereoactive protein. We know we do it when we suspect infection, procalcitonin more than 2, or white blood cell count. So which test to be used to rule in the disease, and which test to be used to rule out the disease? I'll leave you, we'll get back to it. Quick recap here. Which one of the 3 tests should be used in a patient with risk of disease, and why? No, sorry, I can't. So here you need to use a highly sensitive test because you want to rule in the disease, and the pre-test probability is low. However, if you want to, which test in a patient with low risk of disease, and why, you need to choose a high risk of disease specificity because you want to rule in the disease. And when it's back to the question of likelihood ratio, which test will rule in the disease? And we said positive likelihood ratios are the one which will rule in the disease. So which one has the highest? We'll leave the negative and we'll go to the positive because I want to rule in the disease. So I'll go with procalcitonin will be the best marker to rule in infection. And in order to rule in infection, that means your pre-test probability is high. So when a patient comes to you in the emergency room and he is septic and you are 90% or your pre-test probability is high, you need to test with the high positive likelihood ratio and count. However, when you want to rule out the disease, that means your pre-test probability is not high, and I just want to make sure, rule out that this patient has no infection, I'll go with the test with the least negative predictive, least likelihood ratio, which is the C-reactive protein. And this is, I just want to leave time for questions. Maybe we'll have 10 minutes. This is recap for what is sensitivity, specificity, and all the measures for validity. Test probability is high, your post-test probability should continue to be high, even if the test turned, if your pre-test probability is high and you have negative tests, you should not be reassured. Continue isolate yourself, or you should repeat the test later on. Using screening tests with low sensitivity can lead to false sense of security, and when the disease is infectious, it can help spreading the disease. It's uncommon to have game time, so always your critical thinking of what do I want from the test? Do I want to rule out the disease or rule in the disease is a crucial question. Do I want, is my pre-test probability high or low? This is another important question to get the best yield from the diagnostic or screening tests you are using. Worldwide testing capacity for COVID-19 started to increase, and the focus now is toward more testing. However, what is worrisome and what is missing from this intense focus on testing is missing testing characteristics. So we need to pay attention for all the testing characteristics of the current COVID-19 test in order to be able to correctly, accurately interpret the findings. Thank you very much.
Thank you, Dr. Anoud, for this informative presentation. You addressed very key terminologies, actually. And the key point here is to actually come up with the exact or a specific question that you really want to answer or address before you design your study.
Yeah.
Right. So let me go through the questions. BBV and MBV, positive predictive values and negative predictive values. Please more clear the concept.
Okay.
In few words, can you just clarify these two terms,
Sure.
please?
So positive predictive value, imagine you are the physician in your office and you did a mammogram for your patient, and the mammogram test result is positive. Okay? So here, the predictive values, we start with positive test. So the test of your mammogram is positive. Your patient came to you and she asked you this question: what is the probability of me having breast cancer given that you told me that my test is positive? This is exactly what's the positive predictive value. The negative predictive value, my mammogram test is negative, and I came to you and I ask you, my mammograph test is negative. What is the probability of me not having the disease because my mammograph test is negative? I hope it's clear.
Good. Good. Thank you so much. And I'm sure each terminology you mentioned in your presentation requires one full presentation or one full webinar by itself.
Right. Right.
Yeah.
Yes.
Another question. Let's see the questions. في سؤال في البداية كان كيف حتكون طريقة التحضير, but it wasn't clear actually. Is there certificates? I think this is it for you. I don't know if you have any other questions from the audience before we close. We have 6 minutes left. I don't see any questions. Well, thank you so much for your time for this informative presentation. It was very clear. You addressed very key terms for sure, and we thank you for your effort and time and being here with us.
anytime. يعطيكم العافية. Thank you very much. تصبحون على خير.
يعافيك إن شاء الله. بالنسبة للaudience, we thank you all for joining us. I hope you enjoyed this series of webinars. We spent almost 3 weeks with all of you, or most of you. We started with the bioethics and then the research methodology and biostatistics. We thank all the speakers and presenters for their time and accepting our invitation to be with us in such short notice. Again, I need to remind you all that all these talks are recorded and you can find them anytime on YouTube. You can visit Event Tرووب channel on YouTube and you can go back and find all these presentations. Inshallah, this is the end of our webinars during Ramadan. After Ramadan, inshallah, we are working on designing another series of webinars until the end of 2020, inshallah al khair. With this, I would like to thank you all. Thank all our speakers. Of course, this is an initiative. This research training course webinars is an initiative from the E1 Health Cluster Research and Administration. And we will be with you, inshallah, as I mentioned earlier, after Ramadan. Thank you all. Ramadan Mubarak with whatever left from Ramadan, and Eid Mubarak, inshallah, علينا جميعا.
العام والجميع بخير إن شاء الله. Thank you
والجميع
very
بخير
much.
إن شاء الله. شكرا مع السلامة.